Please.
I wonder if you've done a presentation to other plastic surgeons about this, what kind of response you get.
So, this is a new diagnosis. Like I've mentioned, there is no ICD-10 code, which means that it's an identifiable illness. I went through plastic surgery training. We didn't have a chapter on this, or even a lecture or a seminar. But one thing I learned as I saw one patient and another patient, I realized what it was doing, and I take it upon me and discuss. I called my friend up, or another person, or another plastic surgeon, and there are plastic surgeons who have put in 5,000 implants and now are only doing explants, and we know who those folks are. That's a big change. I am going to openly ask my colleagues, my friends, that we sit down and we discuss. We have a responsibility. The patients have a responsibility to be educated, to know who to go to and who not to go to. The manufacturers have a responsibility. The society has a responsibility, because we want to learn from the patients. Ultimately, we want to enhance the quality and the quantity of life so that we live longer and healthier and better. So to answer your questions, 2007, they were allowed back into the market. The manufacturers deemed and determined them to be safe, having said that 1.4 to 2% of the patients are going to have this subset of rheumatological problems, headaches, and whatnot else. We need to go back and define and establish criteria so that we can say, there's the first generation, second, third, fourth, fifth generation, the gummy bears. What we need to do is we need to start discussing. And so this is a very nice, healthy, there's not many of us here. But guess what? This video hopefully will be shared by a lot of patients. Hopefully will spread and be a part of the discussion at the society meetings, so that we start recognizing that, what you heard about 50 signs and symptoms have all, as a matter of time, been eliminated. This is pretty dramatic. This is pretty drastic. And this is real. This is not in the head. This is not a placebo effect. So to answer your question, and this is what I say, every video that I do in the operating room, I'm going to try to put it out so that I can explain my part of the story. The patients are very brave. For them to go, if they are a professor at the university, or if they are a physician at Royal Oak, 2 patients that I did in the last month. Certainly I understand if I don't want to go and share my problems on Facebook. I don't want my patients to know my personal life. That's very important. But I will tell you, as I discuss my experience, and I'm just mentioning to you what I did. This is like what you see is what you get in this discussion. The pathology report, that's real. That's hard copy right out of the hospital right here. So to answer your question, I strongly believe, I wish there were OBGYN docs here, internal medicine, family medicine docs, right here at the hospital. That was one of the reasons why I thought, okay, maybe someone will come for free food, and listen in. I used to do that a lot, when I was a fellow. And so the point is, maybe you learn from someone's experience. Because we're always learning. The dean of my medical school said you're always learning. That's what makes you a better doc than what you were. So hopefully in 3 years, 5 years, we talk more. There is more social media. Someone will step up and say, you know what, I'm going to take that leadership role and start talking about it, because if 2 people talk, they're going to look the other way. If 20 people talk, they're going to say, who's making the noise? If 2,000 people talk, they're going to say, where's that buzz coming from? Let me have you talk about it on this channel, for example. Or if 20,000 patients talk, that's a big voice. Just like the vote, I was on Channel 4, the Live in the D extra show, and I said, you know what, every vote counts. Each one of you ladies who has had the explant and who's gone on Facebook and talked about their experience, Your vote is like a million votes because you're speaking for the many others who may choose not to talk. And so that's why, and again, I say it's very healthy, very natural. We're passing information so that I can tell my colleagues, that video that I made on Plastic Surgery Academy, I speak and I say, dear colleagues, I'm ASPS board certified. This is my experience. This is what my patient came in with. And this is what I am relaying to you directly. Because that's a very effective tool of reaching them at 2 in the morning. If they are stuck at an airport, for example, in Europe, and they have some downtime to look at some videos, because you know what? We're always getting the information. Or when I go, I share the Facebook page, and I tell my friend, look, this is what I had. My friend laughed very hard. It's like, what are you trying to do now? And so the point is that we share, and I say, you know what? This is concrete information. This is real. This is not what they call about nowadays fake news. This is real news. This is real patients, real lives. You have a patient, you have the significant other, you have the sons and daughters, the uncles, aunts, patients not being able to go to weddings, birthday parties, not being able to have a job, not being able to get out of bed. So it affects a whole subset of family members indirectly or directly, I should say. So the more we talk, to answer your question, the more videos I do, and I want someone to teach me and train me so that I can enhance my experience, and hopefully we have, I invited and I emailed some of my other colleagues who do explants only and say, you know what, let's get on the podium and let's have a panel discussion. That's very healthy. Let's share your experience, my experience, and what I told Lori, my office manager, who along with Jennifer helped set this up. We get a series of patients listed, according to any research study, so that we can say these are the subset of patients that I've had. This is what they came in with, or we have like a account of over the years, who are these patients. Now I'll tell you this, as soon as I sat down and I said, you know what, I tried to reach a patient, I could not reach her. And so this is what we're looking at. This is to answer your question indirectly. A patient came to me, 72-year-old nurse, obviously there's no name, no HIPAA violation. She came to me, I took care of her bad injury, and she's like, can you take care of my chest pain? I've had a capsular contracture. She worked at the hospital. And I looked at her and I said, you're 72. You are in the DNT category. You know what DNT means? Do not touch. Because if it ain't broke, don't fix it. And she said, no, I feel like it's getting hard. And she said, I want you to go ahead and take my implant out and replace it with another implant, and you can do the capsulotomy, which is what I talked about earlier. I said, I'm not going to do it because I don't feel comfortable. And given her exam, her presentation, she had signs and symptoms of breast implant illness. This was 3 years ago. I refused. And she smiled and she said, I cannot believe you're refusing. I've got insurance and let's go for it, And I said, I'm not going to do it. Now, 3 months later, I had a phone call from a plastic surgery colleague. This is true information. I can present it on the next presentation or seminar that I have, just so that we can make it a point. I got a call from a plastic surgeon. Can you go see this patient? She is at this hospital. I don't have privileges. I said, sure. I'm going to end clinic, and as soon as and she's like, I want you to go fast because I want you to go there. So as soon as I enter the room, the patient says, I should have listened to you. The next thing you know, I find out, and I didn't know what her name was. I was just given a room number and the information pertaining to the patient. And this was the same patient I saw. She was actually found down by the police, and her son ended up calling because she was not answering her phone and she lived by herself. And she had bilateral right and left cellulitis and septic shock. She was on the ground. And the police came, ambulance came, and they wheeled her, and she needed to get both of the implants out because this other surgeon ended up giving her what she wanted. So this is, and again, this is one case that came to mind, and I'll tell you over the years, there's so many patients that have come because what is the risk for capsular contracture over the years. Very high. And like I said, the average lifespan / of the implants are approximately 10 years, some more, some less, depending on the patient. We need to talk about, and we need to say, do no harm, and offer the patient a quality. And myself, I said no to so many patients where I said, I don't feel comfortable putting in implants. This is not my area of expertise, and I say this very openly. Any other questions? Yes, please.
So, like here, but we've seen a few doctors, but like to have the drains, is it better not to have it?
Okay, so that's a good question. I get this a lot. I did the case last week. The lady right before the case, I was getting informed consent, and she said, you have to put the drains in. I smiled at her and I said, I know the social media is telling you to. I said, I'm going to go inside, depending on my dissection, depending on, now look at my cases I presented. I have that biofilm, I have that ruptured implant, but because I removed everything and I felt comfortable, and you saw the pocket, I want you to go see the videos. Maybe I should show a video, or you can do it on Plastic Surgery Academy. I felt very comfortable going in and saying with confidence, I'm not going to put the drain in. Now, there's two things as a board-certified general surgeon and a board-certified plastic surgeon. If I'm ever sitting on the fence, should I or should I not put the drain? I always put it in. What's the worst thing? I'm going to remove it in 2-4 days. Now, mark my words, is the drain going to prevent a hematoma? 100% not. If you're going to get a hematoma, regardless if you have 2 drains or 1 or 0, you're going to get a hematoma. You have to go back, wash out, find the bleeder, which can happen even in the best of the hands, just like you would, abdominal surgery. So I make it a decision in the operating room from my experience and expertise and say, you know what, I'm going to put the drain in because I want to see what's coming out. It was an extensive dissection. I don't want that as the patient twists and turns that night, where you have the shear forces that will cause fluid to be produced, i.e. a seroma, that may accumulate. Now, if it does, I can always go and aspirate, and you do it one more time and be done. Because the fluid is not going to come, that seroma, it may be necessarily in 2 days or 4 days or 6. It may come 2 weeks later even, or 10 days. So I always put the drain if I'm ever sitting on the fence, and given the nature of the dissection I do, I don't put the drains in because it's not required. Now, if I do an abdominoplasty, 100%, 100%, I'm going to put 2 drains, not even 1. One on this side, one is a backup, because it's going to accumulate. The dissection is extensive and it's going to accumulate inevitably, whether I like it or not. So that's the standard of care. Mastectomy patients who have had entire breast tissue removed along with the maybe sentinel lymph node or axillary dissection, you have to 100% put a drain in. It's a no-brainer. Don't even think. You have to have the drains out on the OR table, because you're going to put them in regardless, even if it's the best, most. Now with the explant, majority of the times, and I cannot remember the last time I put a drain in. So that patient that came in last week who said, I want you to, she smiled and she said, I asked you to put the drain in. Thank you very much for not listening to me. But that's a good question. Yes, please.
Okay, so Renee on our Facebook, she's asking, if you find silicone-filled lymph nodes, what do you do? Do you remove those, and then also do you offer nerve block? And then somebody else is asking, do you take insurance?
So insurance, so let me ask the first question. I'll answer in the order. Number one, if you have silicone in the lymph nodes, how do I know that there is silicone? You have to send it to pathology. You could have inflamed lymph nodes. If I take a knife and cut myself here as a paper cut, and it's a deep cut, let's say, tomorrow morning you come, you're going to find lymph nodes that are going to light up. If I shave and I cut myself deep, you're going to find lymph nodes that are going to light up, because that's my body's defense. Now, how do I know that lymph nodes have silica in it? The only way, you send it out to path. Now, in order to do a lymph node dissection, that's a dangerous game, just like a mastectomy. If you do a lot of lymph node resection, guess what? The drainage of the lymph What do the mastectomy patients get? The whole arm is puffed up like a Michelin man, right? Because it compromised off the lymphatics. You don't want to do it when the patient could have just a reaction to the implant. So you have to prove that silica is there. Is it part of the capsule? It's not. Because that's way far up there. In this basin, the implant and the capsule here is here. So to answer your question, unless you prove there's silica drain into the lymph nodes, because you may have a palpable lymph node, and sometimes people get a lymph node biopsy, ultrasound guided or by general surgery, and it shows lymph nodes that have silica. By all means, go ahead and remove, because that's the body's first set of filter where it's entrapping or accumulating the silica. The second is nerve block. Now, I use lidocaine plus epinephrine. It lasts in the system, and it serves as a very nice effective block. Now, this one patient that came today, that I believe she did not use any Norco because she felt complete relief and she was happy with just Tylenol. Every patient is different. You know, there is tramadol, you can give medications, because no matter what block you give, after 6 or 12 hours, it's only going to wear off, right? So, and where is it going to hurt the most? It's going to hurt the most at the IMF incision, and you have a nice garment. So I ask all the ladies, come in with a garment that's comfortable. It's not going to be a metal wire bra or something that's going to hold against. It's going to give you nice support so that when you walk, twist, turn, there are no shear forces that are basically causing that fluid to accumulate or the swelling. When you have a compression, just like after gynecomastia surgery or abdominoplasty, what do? You put a nice tight binder on so that there is no shear forces as you walk. It's one system, and it does two things. It kind of gives that elasticity of the skin to retract so that you're giving it the support and it's not hanging down by gravity, and also prevents or tamponades that big space. So you see, when I remove the end block capsule, there's a huge cavity, right? So I don't want that fluid to accumulate, and it lays down nicely so that that compression garment works effectively. What was the third question, Tracy?
Insurance.
So insurance, I'll tell you this, and I will tell you, there is very simple. Insurance in, insurance out. Breast cancer was the cause that you ended up getting the implants. Insurance covered. Insurance will remove it. Cosmetic in, cosmetic out. I give the example of someone who gets a facelift and he gets an infection where there is whole scar, contracture, and abscess. You go in an emergency room and you send the bill to the insurance, they're going to like, you didn't need to get the facelift. Had you not gotten it, you would not have gotten the complications. So you're, now they may say the insurances are, as you know, not our friend. And they're going to say, well, if it's a medical necessity, by all means, go for it. We're 100% for the patient on the record. When the whole bill comes from this hospital or another hospital, which is $20,000, they're going to say denied, and now you have to fight. And they say, well, you told me it's a medical necessity. They're going to say, well, cosmetic in, cosmetic out. So the insurance, and unfortunately, now, hopefully, if the right system, the right set of leadership steps up and says, you know what, this is bad, and in the past, this whoever is responsible for this badness is, because, you know, you're signing up for this, they may have clauses and say, well, if there's a reversal, they might cover it. I do not know if there's a class action lawsuit. I do not know. But the bottom line is that is one avenue. But I tell all my patients, don't be waiting and be naive and innocent and expect that the insurance will cover.
Okay, but the question, like with insurance, if a patient gets a pre-approval from their insurance company, would you take it?
Sure.
Okay.
I want to know who that insurance company is.
Right.
You know, because,
Of course,
yeah.
but there have been very few.
Sure.
But there have been a few that have.
No, I agree, because, but I will tell you, see, then this is going to happen.
Right.
You did it for insurance, now I want the same. Then you have a million other ladies that are, because there are unfortunately a lot of women who want to get it removed and not for $1,200 or $3,000 because they feel uncomfortable, and do it right, otherwise don't do it, because you don't want to be causing another problem later on. But I get your point wholeheartedly, yes.
Some insurances will with a fight, and some women have been successful in that.
Sure.
Most aren't.
Uh,
But if someone is successful and insurance will cover it.
No, I will take it. So I've taken patients, yeah, there are not many. No. Excuse me, please? then it's patient's responsibility. Yeah. I will tell you from my experience, zero. My experience, because, you know, the patients I used insurance are the patients who had the cancer. Now, the insurances themselves, if you look at their pages in the brochures, they say grade 4 has to be this, and ruptured implant. They're going to say, well, had you not inserted it? But I will tell you, what's the worst thing that's going to happen? They're going to say no, but I say at least give it a try. Now, the patients that I've sent this to, or you prove with pictures that this is what the patient will benefit from, or it will enhance, because sometimes the insurances say, well, you went to the hospital 10 times, that one patient did, for example. You know how much the hospital bill was for all those problems? You just take them out and be end and done with it, and the end of the misery for not only the patient but also for the insurance, right? Because and again, it's a very tricky slope, and I'll tell you, I'm not a big fan of insurances, as we all know. Yes, please.
I got a question for the guest speaker, if you don't mind. Hi. How long ago did you take home?
April 2nd last year, 2018.
If you don't mind, what did that cost?
I went to Costa Rica for that because I didn't know about Dr. Khan.
Okay.
So, including our airfare for both of us, I was down there for 18 days because when I booked it, we didn't realize that Easter was coming up, and they called and said, we're going to have to push you to the end of the month, and I was so sick, I was going to shoot myself. I was so suicidal. And so I booked it early, and said, can I come down early and do my pre-op? And so we stayed 18 days. Oh, sorry. Oh, okay. I do love talking on a microphone. I do miss talking on a microphone. We were down there 18 days, so including our airfare, food, what else? Help me out here. Taxis, the surgery. We probably spent about, hyperbaric. I went into a hyperbaric, 7 hyperbaric chamber sessions, which I think were phenomenal. I felt like $1 million after each one, and they were $125 each, and you could just go in. In the States, it's not that easy, I guess. But so we spent about, I'd say, 10 grand total.
So that was it was like a package, or the surgery
No,
was separate?
no, I'm just saying when we added it all up, the surgery was 45, and then for the explant and lift. But you can't go by that.
You still had your anesthesiology
Yes,
added
but then,
on.
yeah,
You had
see, the
your
difference is,
operation room added on. It was
yes.
another $3,000 on
It was
top
about
of that. So it's-
7,500 probably for the
It equates to
surgery.
Okay. And that was my other question, is that after you did it, you said it was last year?
Yes, a year ago.
Did you do anything after? A lift or anything?
I did a lift at the same time.
At the same time?
Yeah, yeah, I
How did
did.
that work out?
It worked out great. They look great.
Because some doctors say that,
They won't do it, yeah,
That's a question.
and he can explain, when he explains why he won't do a lift, it makes perfect sense in my
you
head.
do it at the same time.
Right, he won't do it at the same time, and I didn't want to go for another surgery. But when I hear these doctors that say why they won't do the lift at the same time, it makes total sense in my head. But she and I are walking around with an explant and lift, so I don't know. Sorry, Dr. Khan, but he can explain it to you. But yeah, we were fine. But
Okay.
yeah, everything was fine. We didn't have any complications. I didn't have any drains, neither did she, same doctor.
Okay.
But again, I wouldn't have gone there if I had known that there was somebody in Michigan doing this, but
Right, who believed in BII, that's the big thing, is you want a doctor
Yeah.
who believes in that.
Yeah.
Because a couple of the other there's 1 or 2 around that didn't believe in BII, but sure, they'd take them out.
Yeah.
But someone who believes in the illness, that you're not crazy and all that, because after spending years and years going to doctors and they're thinking you're crazy, it's really important to get your PCP on board. And I actually got mine on. He's like, okay, I'll write you whatever you got to do. I still couldn't get insurance to approve anything. So that's why, I ended up, going out of the country. You couldn't get into anywhere around. I had consults in Arizona. I had consults in Dallas. I had consults, and so I had booked with a doctor in Florida and California, and then I said to him,
what's the difference? We have to fly anyway. Why don't we go to Costa Rica and make a vacation out of it? And the before and after pictures of this guy's work is what drove me down there. But then again, I didn't know about Dr. Khan.
Yeah, and what I would like to know is, or I do, is a big thing for us was getting a video of afterwards. Like, I think Tracy maybe gave you her video. I have one too. Of afterwards, they show that you have a total end block. They show the pictures. They give them to you, and show the pictures of your open area here during surgery, and so that you know what is there, and you can see there's nothing left, and all that. That makes people feel a lot better. And then getting the implants back is a big thing, because a lot of doctors won't do that, and that was a big thing also.
Right, and I will, so very important, you know, the implant needs to be given back to the patient, because, you know, this is essentially your property. That's the way I look at it. You have to be 100% transparent. There are patients of mine who I said the capsule was not even present. This was as if you had just inserted it. The patient does an exam post-op and says, I don't feel anything. There's no contracture. I assure you, when she gets a mammogram, she's not going to find anything pathologic. And if it's not there, how can you remove it? Because of the way. It's very analogous or similar to if I take just, for example, an incision, and I have 10 different patients who get C-section scars. One patient may have a scar that's non-existent. They're like, did you really get it? Because they hit it very nicely and she does not form scars. Another patient forms keloid scars. The same thing on the inside. This one patient forms a bad capsular contracture. The other one does not. One lady is living happily ever after and had the best lifetime experience and said that was the best thing ever happened to me my whole life. We have heard this too many times, right? But then the subset of patients who did not have the peanut allergy, for example, but someone like you may have, and that's why you're mounting the response. You have breast implant illness, and that's why you need to take it out. So to answer the question, it's very ill-defined, but if you look into it and you ask the right questions, you will be able to direct and say, this is what's the problem, and only after the fact, after the explant is done, you can say that this is, I sought a relief and resolution, let's say, for example, the 50 sign symptoms that I presented with.
Right. How can we educate our PCPs to just, when people come in with unexplained symptoms and they run the labs and labs are negative or nothing's turning out, yet they have all these symptoms, how do we educate them to even ask, do you have breast implants, or even believe that maybe...
So I will tell you, this discussion right here, the discussion, hopefully I can able to, I'm going to, again, reach out to my colleagues in California and Cleveland, whoever does explants, the doc in Costa Rica, very nice doc. So we can sit down and see, you know what, can you talk about your experience? Can you talk? And then hopefully there's another PCP sitting in the back listening next time we have something like this and says, oh, okay, I'm going to bring my partner because you know what, I have a patient. Because they're not believing in it because it doesn't exist in the textbooks. But we need to recognize that it is real, and this is not something that I have or you have or we have created. I just got a question. Just 1 second, please. So Facebook question. You know, she had the explants done, and the patient had capsular contracture. The implants were removed. The capsule was left behind. Typical, standard. Don't listen to me. Listen to my slide where I said the 6/11/2019 silica and the capsule. That's residual disease behind. This is just like saying that it's an incomplete job. You have to go remove the capsule. So guess what? I'm going to tell the patient, you need to have an ultrasound so we define how and what this pocket is, where it is. So now you have identified what this capsular contracture that this lady has, for sure, because it was hard. And then I know as I go in that if I were to take care of this patient, I do not know where she is, but you need to have an explant surgeon who's going to remove the capsule in its entirety. And the second time around, hopefully the entire capsule is there so you can remove it as one piece rather than in pieces, because they might have removed some 50%, leaving the other 50. You have to remove the whole capsule because in it is embedded the silica, as we saw. Please.
I have a question for you. I had my cancer and I needed a double radical mastectomy because they only gave me 3 months.
Please go ahead.
And my question is, why I didn't even have any reconstruction in my mind. Why did they push it after I had that done?
You know,
They say, you feel better, you feel more like a woman. I didn't even have that on my mind. I had so much,
so
turbulence and
I will tell you, if you went to another doc, they might not have even brought it up. And so it is, lack of a better word, dealer's choice. That's what they wanted to offer you. If you go to a major medical center, they will say in the breast cancer center, you have a whole subset of surgeons, radiation oncologists, to the surgical oncologist, medical oncologist, you have the imaging specialist, and then you have the plastic surgeon, because now all of a sudden you're rotating through, and this is what they're going to offer because that's what they offer. You follow? And they say that's an accepted. Now, should there be a choice that you as a patient have to make? Now, there's another patient who I took care of, and she said that she did not truly get an informed consent. She did not know what she was signing up for. And I said, well, that's a decision where, you have the obligation as a physician discussing with your patient, because this is not risk-free. There's nothing risk-free. This is extra. I'm like the minimalist. If I can avoid something in my life, in my patients, I avoid it. I'm a big fan of DNT, do not touch. If it ain't broke, don't fix it. If you can dodge surgery, that's the better option always. And I'll tell people all the time, I love to operate. That's my cup of tea. If you want to have me do something in my spare time, I'll probably be operating, because that's what I signed up for. But I tell all my patients, patient comes in, and this is my practice, for example. A patient has a ganglion on the wrist. I do hand surgery as well. And I say, how much does it bother you? And I ask them, 10, I cannot function. 1, it's unsightly. It doesn't look cool when I shake someone's hand. I say, you know what? I'll see you if it gets larger, or if you start bending your wrist, it becomes a problem. Another example, just to expand on this, someone comes in with a mallet deformity, and the finger is dipped. I give him mallet splint, non-operative. I've never operated on a finger. Because I said, if I go in and infuse the finger, when you make a fist, the finger is going to be sticking out. I've done you disservice, now you're dropping the penny. Goal is to hold on to something. So what if it's bent? Now, there are other problems that may occur, or if I can fix it with, like least intervention, that's the smarter way of taking care of the problem. So to answer your question, it depends on who you go to. Now,
I had a wonderful surgeon. He came from New York, from the clinic where he lost his wife of cancer to his cancer specialist in Lansing. And wonderful man. But then another plastic surgeon came and suggested it to me, and I had no idea.
Right.
I was still in bad shape and everything, yeah.
See, when you go through that stage in your life, and we all know family members, friends who have gone, when you hear the word cancer, you don't hear anything else. You're mute. And you just, where do I go? Where do I go next? And the next thing you know, you're in this queue, and you're essentially not able to think, because all what you're thinking, it's like learning Chinese. It's a new language. What's the standard? Or you just go here, and this is what happens next, and you just kind of are true. Now, if you remember, one of the things that I mentioned initially was the audience here is the patients who have implants. The audience is the significant others who are, because living with and will eventually live with their spouses who are going to have implants. And third, there was a high school student asked Jennifer, who wants to come and shadow me. She's here for summer break, and she wants to shadow. I said, come here. I only have one request. I'm going to ask my patients if you can come in and listen, but you have to do one thing. You're going to write about breast implant illness when you go back to college, because I wanted to teach your friends what you saw and learned from just one day. And she's like, wow, I didn't know this. Now, I'll tell you this, she will never get implants in her life because she heard the patients directly. And I said, you know what, when you go back in your college newspaper, what was my summer? Write an article. It might touch someone, and that one experience might be someone's Misery prevented. Yes, please.
Live in Novi. I know.
And I just want to say that they stole almost 26 years from my life. I had them for almost 26
Can you please do me a favor? If you can come and talk, that would be great, and I appreciate it, because I have, we have an audience that is international, that is all around, and who will listen, so we want to share your experience, please. Thank you very much.
Yeah, my implants stole almost 26 years from my life. I was told they were safe. I had saline, so I thought, okay, I did the right one, And I had probably 40 to 50 symptoms. Everything from I couldn't get off my couch to depression to, oh my gosh, I could go on and on for hours. And that's not me. I'm the Charge the Hill girl. I run my own business. I do all kinds of stuff. And I had so much pain. I had weekly or twice weekly migraine headaches. I was like you. I eliminated so much out of my diet just to try not to have headaches. In the 7.5 weeks since I had my implants out, I haven't had one headache, not one. It's taken vacations from me. It's taken time with my children. I lost 12 pounds, like, boom. Like, the inflammation was amazing. I feel like I'm 61. I feel like I'm 30 again. And I wish I would have known about you. And I will tell so many people about you being here in Michigan, because the doctor I went to in Nashville was awesome. He was a microsurgeon, and definitely go to a microsurgeon because they're definitely worth it. So definitely.
Thank you very much for sharing your experience. And so this is, you asked a very smart question at the end, how can we change? She just made a change because she got up and she talked about her experience, because what she went through right now, that's her life. It's very real. 26 years. Who was president 26 years ago? Long time ago. Yeah.
26 years. It only felt like 26 years. Sorry, everyone.
So this is like, I'm assuming the Clinton time. So that's how old what you lived with, and this is what the whole point is. Now, you made a huge impact right now, because someone in another part of the world is going to say, you know what, that's exactly what I was experiencing. And I was a productive part of society, just like Tracy said. And I will tell you this, I could have gone, if I was in the 70s and 80s, as a plastic surgeon, gone on my whole career not putting an implant. Now, all of a sudden, I was doing a lot of good reconstruction. All of a sudden, patients would come, I would do the explant, not talk about it. I just made my YouTube channel like 2.5 weeks ago, thanks to MPH right here. They've been taking care of me and getting the word out. And they basically, I post a video on the 1 in the morning, it's there at 3 in the morning, it's posted. They take care of, and you know what? Together, all of us will make the change. Now, I will tell you, you just need to keep talking. Hopefully a seminar like this, I'm going to go and I'm going to reach out to my other explant surgeons exclusively. There's another doc friend of mine in town. He's not put a single implant in. And he's, again, the same thought that he said, I would do something else because I don't believe in it. You know what I'm saying? I don't want to do no harm. I will tell you, it's very easy to put in implants. As you see, dermatologists are doing it. OBGYN docs are doing it. Hair transplant surgeons, general surgeons are doing it. And the point I'm trying to make here is it's not as simple as putting an implant in and have a nice life and live happily ever after. That's absolutely not the case.
Because more and more happens, and hopefully FDA things start coming about.
Right,
that,
yeah.
I mean, more people are getting educated all the time, and I just hope that more and more people will show up to these kind of things.
Right. There is, from my experience, if you take my general surgery part of the training away, I will say I'll deflate when it comes to my training. When there was a patient that, and again, I'm going to speak my mind, as you probably know and realize, a gunshot wound to the chest. All of a sudden, you have to do the protocol, take care of business. there were friends of mine who were saying, what are you going to learn from that? I'll tell you this. This is coming into play right now because I can dissect off the chest wall. Number two, being able to, I gave the example when you have bowel adhesions and you have to be very meticulous. I loved the thyroid surgery because you have to be very precise. One bad move on the thyroid, you could end up in a hematoma on the neck. Or you're off by a little bit on hand surgery, and the next thing you know, the patient has permanent ligament damage. So it's all about defining the right tissue plane, as you saw. If you look at the videos, making the right dissections. When I do the nerve repair, artificial cadaveric nerve reconstruction because the patient had a tumor, you bring the scope out and you connect with 8/0 nylons, same meticulous dissection, and you're offering that experience to the patients with the capsule because, again, the take-home message is the capsule needs to go.
Renee wants to know if pathology comes back with bacteria or fungus, do you offer a treatment?
100% infectious disease. They need to jump on the patient, and they need to basically make sure that when they grow the bacteria on the petri dish, that it is susceptible to the antibiotic that you're going to give, that's not resistant, and that you have a definitive infectious disease. And they do bugs all day, microorganisms, resistant, special bugs, fungal infections, TB. When that one patient in my training who had the TB, infectious disease was the next consult. They jumped. You have to treat like you would indolent TB because we don't want a recurrence. So you have to get the right appropriate team involved so that we can tackle the microorganism accordingly. So normally I will tell you this from my experience, I don't like to book 6 months out or 3 months out. Every patient that comes in, Jennifer, she walks up to me and she says, do you want to see this patient? And I say, yes or no. I work almost 100 hours a week. And I will tell you, the day before, I slept at 4:20 just because I had to take care of, present, make sure everything was good. Ask Lori, I'm behind in billing for 2.5 months for my other, she will tell you. And so, I have a full life. The point I'm trying to make is I'm working. I don't want to see a patient and the next thing you know, I book them 4 months. And when I see them again, I'm like, so where were we? I want to have a fresh image, a fresh picture so that when I offer the service, I'm able to offer definitively. So I say I block at 3 for 2 reasons. So 3 is a very healthy number if I start at 8:30. So I've been doing consecutive 3 to 3 on a Tuesday morning. I don't like to operate on Fridays or the weekend. So earlier on in the weeks, just so that if there's any issues, anything, I'm there to take care of it. So 3, and I will tell you if any explant surgeon is offering and they're done in an hour, hour and a half, there's a problem there. So one day, yeah, yes. Right. So to give you an example, like today I did 5 cases. These 6 cases, and so this is enough. And Jennifer, you should have seen me. She was like, "You better be on time here," and I had to do another surgery, but we ended up putting it on for Thursday morning because that's the reconstruction I have to do. So I will tell you. When a person cancels, I'm like, thank God I'm going to go home.
But these were all minor procedures, they weren't.
Right. Yeah. So I had, right. So just to give you an example, I do all sorts of reconstruction. This is what I was doing, like Integra reconstruction, which is artificial skin squamous cell cancer. I did a carpal tunnel on a physician today, basically under local, no general, no sedation. The third one was a lesion, what was potentially melanoma, on the breast of a lady. She came referred by a dermatologist. The fourth one was, and again, these are, I had a extensor tendon that I did. Again, very meticulous, sophisticated surgery, hand surgery. It's very delicate. I say if you can do hand, you can do everything. The hand's very tricky. Yes.
A couple basic questions that people had.
Yes, please.
For example, how soon can they drive after surgery? Will they be able to lift, like activity, right after the explant?
Sure. So that's a very good question. So there, it matters on where the implant sits, above the muscle or below. Now, this was one of the remarks I was on the Live in the D Extra, and someone's like, oh, my guest was on TV and she's driving day 3 and giving an interview. That's like, no, we have to look at that patient, and some of the patients did comment on the internet. You cannot just conclude from that what happened. There's a whole story and series of events that led to that, surgery and post-op. So to answer the question, if the implant is below the muscle, it's not ruptured and doesn't have a capsule, and the dissection is, now there's different ways you can put behind the muscle. You can put with alloderm, for example. You can put without. You can put it half sticking out, half under. Someone who's working out, for example, and the muscle has atrophied, depending on the age of the patient, when you dissect around the muscle, you're definitely going to be sore. So you cannot lift something up. But as far as moving your hands, your fingers, that's not going to hurt. So I say, and I leave it up to the patient, as long as you're not on the pain meds, your reaction time is good, and that you're able to be fast, because driving is all about reaction time, and you're as fast and quick to respond, then by all means use your judgment, and you can do it. So most of my patients, if I do operate on Tuesday, for example, or Monday, I say give yourself, do a test drive by Wednesday, Thursday, Friday. Definitely by Monday they're back at work, from my experience. So I saw just today one patient. She is a week out. She's smiling. She's wearing the pressure garment, which is very important. And I have another patient that she's smiling here. So she felt very good driving in 3 days. And this was the patient that I put the picture up. And this was one of the videos. And I just put up the videos because someone said, you know what, can you please show how you do it? And this or that. And in it, I show my colleagues as to how I do it. Hopefully that helps you.
I have there's
Yes,
two other
please.
questions. Do patients have to sleep upright after the explant, and are there any sleeping restrictions?
So I say listen to your body. The one restriction that I have is you can walk, that should not be a problem, as long as you have a garment that's going to help protect and prevent the shear forces that will move the skin off the chest, because you want it nicely, tightly adherent. So no shear forces, because that will induce a seroma. Sleeping upright helps, because that's the gravity, and also helps with the breathing, if you ask me. But it is not, if anything, almost all my patients, and I think the ladies over here who have had the explant say they slept better the same night because they had less of a breathing problem, the chest weight, now they may have the soreness, but almost always they sleep better, and you can certainly sleep supine, i.e. flat, and it should not be a problem.
Okay. And then, will my breasts be uneven after explant?
So this is a good question. If you look at the anatomy, no two sides are similar, period. There's one is always larger than the other, but not a whole lot. But one thing I say is, if you look at the patient that I had up here, or the patients that come, sometimes the patient has a capsular contracture on one side and nothing on the other side. There's much more swelling on the capsular contracture side, different pathology, different disease process compared to the patients on the other side who has had the implant, but there is no capsular contracture. So the swelling is going to be different. The tissue, the swelling, all of that is going to recede over the next several weeks and months, and it takes up to, if you ask me, up to 9 months to a year, just like a patient who gives birth, for the abdominal muscles / the subcutaneous tissue to normalize and equilibrate. So I say, but the gist of it occurs within the first 2, 3, 4 months, and it plateaus depending on. Now, most of the patients, if you look, who have implants, you can see the engorged veins, these green veins that light up. That's swelling. That's like the body going on overdrive. So I say to the patients, and this is a follow-up for your lift question, I say, you saw the big flaps. You want to put more scars over there? You read a review when you were up here on that patient. She was so happy. You know what she told me today? Thank God you didn't do the lift. I said I was not going to do it to begin with because I do not know when the skin retracts where and how it's going to settle. Because I don't want to do a lift and the next thing you know it settles more and now you have a awkwardly placed nipple areola complex, which is a very, very hard problem to fix. Come back, step 1, get rid of the problem. Step 2, come back another day. If a lady comes, and see this is very deep thoughts now, 21 years of age, large bilateral breasts, huge breasts, what they call, because of the hormonal changes, genetic. If you do a lift on her at 21, she's going to be back in her late 30s saying, I want another lift because of the gravity effect. It's only going to sag, inevitably, unless you're on the moon, right? So this is what my boss used to say. So in honor and recognition of, and it's very true because now I was able to comprehend. So I say let it settle. When it settles, maybe you might not need one because you're young and 26 and it's going to retract, and guess what? The skin does retract unless you're postmenopausal and the skin has lost its elasticity, and it's going to continue to sag. Come another day and then do it defined. You come in and out. I have you on the OR table for 3.5 hours, 3 hours, 4 hours. One other lady was here for 4 hours on the table. I don't want you to be on the table for another 2 or 3 hours. That's 6 hours. Right off the bat, I'll tell you 6 hours or more on the table, you increase chances of DVT, deep venous thrombus, you got increased problems of infection. The goal is the Navy SEAL. You got to define operation, take care of business, come right out, do it another day. And so that's my take on. Now there are patients who get this concentric perioral lift, crescent shape. There are a lot of problems that come with it. Look at that. Do you want to go ahead and do it on that? And the next thing you know, you alter the nerve supply to the nipple. That's a big compromise. So you don't want to do that. All right? So the dissection is not as simple as it appears to be. And surgery is a very deep, thoughtful, and very sophisticated process. Every patient is different. I'll tell you to this day, when I go in and I say, I hope that, it's not going to be a challenging case like when I went in. It was a ruptured implant with a hematoma. When I came out, I felt like I need to sit down. I feel like I'm 80 years old, because I'm tired, the dissection, and it's mentally draining. That's why no one wants to do this end block business. It is, as you have heard from the other surgeons, it's a tiring process. Hopefully that answers the question. Okay. So thank you very much, everyone, for coming. Thank you very much to my audience, whoever you folks are. I hope you found this useful. I want you to please go ahead and talk about it. I apologize in advance if I said anything that may have offended someone. I will tell you I spoke from my heart, and again, from what I know, so that someone who got the implants and is doing well, good for you, and hopefully you don't get this problem. If you do, and you know someone who needs help, get the assistance, because there is help, there is hope. 26 years is a long time. 26 years ago, I will tell you, I can only remember what I was doing, and so you have to basically, I was at UT Austin then. I was a Longhorn a long time ago. So you have to listen to your heart, what you're going through. And I say this, the patients are smart. You know what's going on deep down within. There's a problem. You use your gut instinct. Look at all these ladies that go in, I knew this was a problem, and they know. Now, you may be wrong, but you have to do the subset of problems, i.e. the checkup, make sure you're not missing something, and then you seek attention, and then by process of elimination, if you remove the implants, hopefully you solve the problem. All right. Thank you very much, everyone. I appreciate it.